I'd like to talk about our glabellar complex. When injecting neuromodulators here, it's considered one of the simplest, but yet one of the most complex areas to treat. And I also want to talk about an exciting study that was released last year in regards to injecting the glabellar complex. I think that it can improve safety in our field, and providers should review it and really take it into consideration. So let's talk further about it. So when talking about our glabellar complex, this is that group of muscles, our medial brow depressor muscle that pulls downward and medially, and that's also known as the frown. We were originally taught to treat that glabella with neuromodulators with a standard 5 injection points with the exact same amount of product. However, each person's anatomy is unique, and this one-size-fits-all approach is not necessarily ideal for everyone. Understanding the glabella and how each muscle functions will guide the clinician in their patient assessment to better understand where the patient needs to be injected and how much to inject, so the patient will have an optimal outcome. Our glabella is made up of a group of muscles. We have the procerus in the middle, and then we have our corrugator supercilii, and then our depressor supercilii. We also have the medial portion of the orbicularis oculi muscle. These influence our eyebrow position, and therefore it's preferred to include the glabella when treating our frontalis muscle. There are vessels that run deep and pierce the corrugator supercilii and the frontalis muscle, and they continue to run up to the superficial surface of the frontalis. It's good to be cognizant of where these vessels typically lie so they can be avoided when possible to prevent bruising, especially with filler use to prevent an occlusion. Our procerus is the muscle located right between the eyes and can be found by connecting both canthus. It can cause a horizontal crease above the nose. Anytime a crease is present, there's a muscle that is running in the opposite direction. Since the crease is horizontal, that procerus is vertically oriented. This originates from our nasal bone and then becomes more superficial and connects to our frontalis muscle. The frontalis is an elevator muscle, so it's preferred to avoid the lower portion of the frontalis to keep the eyebrows lifted. For this reason, it's better to inject in the lower portion of the procerus to avoid hitting the frontalis. If the procerus is injected too high, the frontalis will likely be affected, causing the medial brows to go down. Sometimes the nasalis muscle can contribute to the horizontal line typically caused by the procerus. It is important to have the patient animate during assessment to see what muscles are moving so the contributing muscles can be treated. Animation will also help identify if the patient has a classic frown pattern or an omega pattern. This will guide the clinician on where to inject. Our corrugator supercilii is the muscle that pulls the brow down medially and inferiorly. It starts medial deep on the bone, and it runs lateral and becomes more superficial across the brow, typically stopping before the mid-pupillary line. Occasionally, it can extend beyond the mid-pupillary line. Like most muscles, it communicates with another muscle. The frontalis overlaps the corrugator supercilii. If the medial injection is not deep enough, it may also affect the frontalis, potentially causing an angry look from a lower medial brow. The lateral portion of the corrugator supercilii attaches superficially to the skin, so lateral injections need to be superficial in that subdermal layer. In the event that the injection is too deep, product would be injected under the muscles, creating a potential for a larger spread and potentially affecting the levator palpebrae muscle, causing an eyelid ptosis. If the injection is too high, it can affect the frontalis. Making sure to inject where the skin appears to be pulling will help avoid this. Upon evaluation of the corrugator, if there is no significant lateral pull, lateral injections may not be warranted to achieve correction of frown lines, and and therefore a 3-point injection technique can be utilized. And this came from an article that came out in 2021 that one of the authors were included was Professor Cotofana. Orbicularis oculi also overlap superiorly and can cause some of the vertical frown lines that is also effectively treated with very superficial injections. Our depressor supercilii muscle lies medial to the upper portion of the nose, lies between the procerus and the corrugator, and pulls the brow inferiorly. If an angled, more medial line is present, the depressor should be treated. Laterally, near the tail of the brows, our orbicularis oculi can pull the tail of the brow down. So a patient that would like an eyebrow lift, in addition to treating the glabella, it's also common to treat this portion of the orbicularis oculi. Keep that muscle from pulling down. On the other hand, if prior to treating, the patient can raise their eyebrows and their brows spok up, it would be expected that they will also spok up after treating the glabella as well. So the lateral frontalis injection should be considered to prevent spocking at the time of that glabellar treatment. Prior to injecting, it's important to take a picture of the patient looking straight ahead and evaluate the patient for their eyebrow and eyelid symmetry. Oftentimes, one eyebrow or lid may sit lower than the other. Notify the patient if they have that lower brow or eyelid, since patients often don't start staring at themselves close enough to notice these things until after their treatment. Neuromodulators can help open up the brows, improving symmetry. There is a risk of eyelid ptosis from the neuromodulator getting into that levator palpebral muscle, and that risk is about 1%. So making sure that the injection is superficial and slow will reduce the spread. Also, using low quantities of liquid for dilution can also reduce this risk of spread. To further reduce eyelid ptosis risk, the thumb of your non-dominant hand can be placed just below that orbital rim on the side during injection. When treating the glabella lines, it's important to take into consideration what's the safest approach to achieve the desired end result. And typically, neuromodulators can efface lines of the glabella, but sometimes fillers are chosen to treat these lines. That's often in cases where the lines stay persistent despite neuromodulator treatment. There is a risk for arterial occlusion that can cause scarring or possible blindness with this treatment. So to avoid potential catastrophic event, neuromodulators can be injected to keep the area from moving, and many of these lines fade with time. Yes, there are instances where these lines are too deep and it does not efface enough to satisfy the patient. And alternatively, some may refer out to experts who use ultrasound guidance, or they inject very superficially into more intradermally into that dermis. If you like this information, please like this video and subscribe. And if you have any suggestions for future topics, please leave them in the comments below. I'd love to hear from you.